Yeah. A very good afternoon and a very warm welcome to today's NITRD Central TB Division and National Task Force Collaborative Difficult to Treat TB Clinic. I am Dr. Neeta Singla, and on my right is Dr. Rupak Singla, who is head of the Department TB and Chest at our institute. And on my left is Dr. Amitesh Gupta, who is a senior chest specialist at NITRD. This clinic is supported by Echo India, and we have Mr. Gaurav, Mr. Prateek, and Mr. Rahul, who are supporting us, along with backend team of Echo India. I extend a very warm welcome to all our seniors here, our senior faculty from Central TB Division, NIRT Chennai, NTI Bangalore, and medical colleges, all the state TB officers, directors of STTC, district TB officers, medical officers, and all others. A very warm welcome. Now I request our director, Dr. R.K. Diwan, to give his opening remarks.
Good afternoon, everybody, and thank you so much, Dr. Neeta, for inviting me. As all of us have been seeing for the last so many months now, difficult to treat Echo Clinic has become a very regular feature of the academic activities of NITRD as well as this platform, Eco platform. And as I already note, 98 participants have joined. And on behalf of the institute, I welcome all these participants and many more who are likely to join soon in the course of deliberations. We also welcome the senior faculty, the guests, as well as people from the CTD, the directors, as SMOs and other people, those who are care to join this institute, this clinic. I'm sure today's deliberations will be as fruitful and as academically enriching as they have been on all previous occasions. Thank you so much, Dr. Neeta. Best wishes. Next.
Thank you. Thank you, Dr. Diwan, for your encouragement. Thanks a lot. And now we straightway go to our case. The presenter of the case is Dr. Naseem Saikai from Dibrugarh, Assam. And the expert for the day is Dr. Rupak Singla. And we have a national expert, Dr. Behra. Dr. Behra is Padma awardee and everybody knows him. I need not go into his introduction. A very warm welcome, Dr. Behra, sir. Yeah, Dr. Behra is there. And now, sir, I hope you are able to hear us, sir.
Yeah, I could. Yeah. Good morning. Good morning, Nita, Rupak, and Dr. Diwan. Yes, yes, I could hear you. Please go ahead. Thank you. Good afternoon, everybody.
Yeah. Thank you, sir. And now I request Dr. Naseem to present the case. Dr. Naseem, you may say hello to everybody before you start so that everybody can see you.
Good afternoon, ma'am. Good afternoon, sir, and all the faculties. I'm Dr. Naseem Ahmed Soikia. I'm from the Nodal DRTB Center and the medical officer here, Dibrugarh, Assam. Today, I'm going to present a very difficult case, which was under our treatment since 2017. It was on and off. She was on different regimens and on different drugs, and this resistance pattern also changed. So it was a very difficult case, and still she is under treatment. So we'd like to present the case and we'll discuss the case further. So may I share the screen now, sir?
Yes, Dr. Naseem.
Is the screen visible, ma'am?
Yes, Dr. Naseem, it is clear and we can see it.
This is a 59-year-old female patient. She was a diabetic and hypertensive. Was referred to the.
Your voice is going down. Can you be a bit louder?
This is a 59-year-old female. She was diabetic and hypertensive and was referred to the NITRD through difficult to treat clinic in July 2021. And past history revealed that she was first admitted at NITRD on 29th of August 2019 with complaints of fever, loss of appetite, loss of weight for 4 months, and loss of weight for 4 months, then weakness for 3 months. She also had a history of tubercular pleural effusion and had taken anti-tubercular therapy from May 2017 to April 2018. This is the X-ray of her taken on 29th of August 2019, which showed a pleural effusion. And the investigations which were done prior to admission in August 2019 were sputum gene expert was done, which showed MTB was detected and rifampicin resistance was found. Then CT abdomen was also done, which showed irregular wall thickening in the pyroduodenal region. Peritoneal biopsy showing non-caseating granulomatous inflammation. Then sputum LPA and MISIT, the reports of which were awaited. Following admission, the patient was started on shorter MDR-TB regimen on 29th of August 2019, consisting of kanamycin, high-dose moxifloxacin, ethionamide, clofazimine, pyrazinamide, high-dose isoniazid, and ethambutol. Sputum LPA and MISIT were sent, both of which were smear negative. Then sputum LPA done at a private laboratory in Assam, done on 27th of August 2019 and reported on 4th of September 2019, which showed the following pattern. Isoniazid high-level resistance was found and rifampicin resistance was found. Fluoroquinolone was found to be resistant and second-line injectable was sensitive. But since the report was from a private lab, so the physician decided to wait for LPA from NITRD. Shorter MDR-TB regimen was continued. Then culture report done at NITRD were later available on 19th of September 2019, and LPA done at NITRD on culture showed the following pattern. Almost similar, isoniazid high-level resistance was found, rifampicin resistant, fluoroquinolone low-level resistance was found. Then second-line injectables was sensitive. Then culture, MISIT, DST report were awaited. On 19th of September, patient was changed the regimen and put on a different regimen. And she was put on moxifloxacin high dose, linezolid, clofazimine, cycloserine, pyrazinamide, and injectable kanamycin. Since bedaquiline was not available at that time, so she was put on that regimen which was available according to the 2017 guidelines. This regimen which are not without the newer drugs. Then the above regimen was to be reviewed after extended DST report. On 29th of September 2019, kanamycin was stopped due to abnormal audiometry and replaced with ethionamide. The patient was discharged on 29th of September 2019 with treatment regimen consisting of moxifloxacin high dose, linezolid, clofazimine, cycloserine, pyrazinamide, and ethionamide. Then extended culture and DST done during the admission September 2019 showed the following results. Here, ethionamide, pyrazinamide, levofloxacin, moxifloxacin. The moxifloxacin low level resistance was found. And moxifloxacin high dose, linezolid, clofazimine, pass, second line injectable were found to be sensitive. However, this report was missed and no action was taken on till February 2021. From 29th of September 2019 to February 2021, patient continued on moxifloxacin high dose, linezolid, clofazimine, cycloserine, ethionamide, and pyrazinamide. In February 2021, pyrazinamide and ethionamide were stopped since they were found to be resistant. From February 2021 to mid-May 2021, patient was on moxifloxacin high dose, linezolid, clofazimine, and cycloserine. She had not been on any medication for the last 1.5 months. Severe effect from May 2021. Two sputum reports from private laboratory were done. Sample sent on 16th of January 2021, reported on 13th of February 2021, showed culture positive, but no DST was available. Sample again sent on February 2021 and reported on March 2021, culture positive with following DST pattern. Here pyrazinamide was found to be resistant And moxifloxacin, clofazimine, cycloserine, linezolid was sensitive. Previously, moxifloxacin was resistant. 2 samples were also sent under PMDT. Sample was sent on 13th of February 2021, reported as culture positive on March 2021. Sample sent in March 2021, reported as culture negative in May. No DSCs were available and could not be traced through Nixoy ID. On 17/6/2021, ECG showed right bundle branch block with QTC-B showing 493 milliseconds. In July 2021, patient had uncontrolled diabetes with serum creatinine of 1.5 mg per dl, indicating eGFR level was 35 ml per minute per square millimeter. These are the radiological features. In July 2021, patient is currently afebrile. However, her cough has persistent and radiological deterioration with appearance of new infiltrates in the right lung. So in January 2021, her X-ray was still deteriorating since January 2021. And in August 2021, new infiltrates were found. Now, in July 2021, the current issues are patient had taken second-line drugs for almost 20 months, and moxifloxacin 2 gram, clofazimine, cycloserine, linezolid are sensitive repeatedly, but patient continued to be culture positive and deteriorating radiologically also. What could be the reason for this? And what should be the current regimen for this patient with uncontrolled diabetes and other comorbidities? On 17/6/2021, ECG showed right bundle branch block with QTC-B showing 493 milliseconds. How to manage that? And in July 2021, patient had creatinine with 1.5 mg per dl, indicating eGFR 35 ml per minute per square millimeter. How to manage with this renal impairment? Patient referred to difficult to treat TB clinic in July 2021. Thank you.
Thank you, Dr. Naseem. It's a very well presented case. And now we started with about 80 spokes when we started the clinic, and now we have more than 230 people who have joined us. So I would just brief the case for people who have missed the introduction. It's a 59-year-old female, and she has been on treatment since 2017. And since 2019, she has been on DRTB treatment. And she has been on individualized treatment earlier because bedaquiline was not available at Assam in 2019. And she is still culture positive in 2021 when the patient was referred to difficult to treat TB clinic in July. And she has a DST pattern where she is resistant to most of the drugs like ethionamide, parazinamide, levomoxy, along with rifampicin and INH. And her X-ray has been deteriorating since then, and she was referred to difficult to treat TB clinic as she had other comorbidities like diabetes, blood pressure, and then she has kidney issues, and there is QTC prolongation. So now I open the case to all the participants. You may ask any question that you have from Dr. Naseem, and if you need any more information, or if you'd like to comment on the case. So are there any questions from anyone?
Yes, yes. So should then Nita, who should start it now? Dr. Nita? Dr. Nita?
Rupak has to discuss the case. Rupak, Dr. Rupak.
Yeah, Dr. Singla, you have to start discussing the case, or what? Who should move?
Sir,
Dr. Singla?
Their connection perhaps is lost.
The connection is lost, I think, sir, with the
Yes.
team, sir.
So Dr. Behra, you can also continue discussion.
Yeah, so that's what I'm
They
telling, because there
join.
may
You
be
can
some
continue, sir.
discordant, so that
Yes, sir.
Yeah,
yes,
sorry,
this
sir.
is a,
Sorry, sir, we got disconnected. Can you hear us, sir?
no, I think let Rupak continue now,
Yes, sir.
because I was just going to start. We are waiting for
Yeah.
you.
Sir, we got disconnected due to electricity failure.
Acha, no
Sorry. So, sir, were there any questions from the audience for Dr. Naseem? Have I missed that portion?
No, there was no question. Only
Okay.
I asked one question: what happened to his pleural effusion part? Was it a dots therapy?
Okay, sir. So, Dr. Naseem, have you answered, sir?
Yeah, he answered. It was
Yes, ma'am.
dots therapy,
Okay, and we
and
have
it
one
was
question on
continued
the
for
chat.
1 year. He's telling.
Dr. Behra, sir, I got one clarification from you, sir. Dr. Behra,
Please.
I think the Vedaculin was available in 2019 in Assam.
That is what I had kept it for my comments. So let Dr. Rupak go. That's what I'm telling. Why Bidaquilin was not given at the. He told only one thing. It was not available. Maybe
it was available, sir. It was available.
yeah, it should. It was available. He told that it was not available. Maybe
yes.
his state
Sir,
was not included.
may I comment, sir? Sir, may I comment?
Please.
Sir, in 2019, Bedaquiline was available, but for some time in between, there was not available. And the availability was an issue. So I think at that time only the patient was started on that regimen.
नहीं डॉक्टर साहब देखिए व्हाट जो very pertinent question Dr. Bharadwaj asked when Bidaquilin was available or issued, obviously let us listen from Dr. Singla. Actually here this is a fit case.
Yes,
Then
sir.
she should have gone on to the Bidaquilin containing regimen, although now you are telling there is some ECG issues. Forget about that, but that is what was in my mind also. And maybe that at the end I will give the comment on that. So maybe Dr. Rupak can continue now. Dr. Rupak.
Thank you, sir. Dr. Talha has raised his hand. Dr. Talha, if you want to ask a question. Doctor. Yes.
Hello, everybody. I am Dr. Talha Saad from Government Medical College, Sagar, MP. I listened this case, but perhaps I think the compliance is a big issue. So for the first time, when the dots was given to that particular lady, so was the compliance enough for the completion of the whole of the 6 months of the treatment for that pleural effusion? That's my first question, because all the time compliance is a very big issue. I have seen so many patients who always used to say that I am taking medicines very properly, but one or twice they always
Sir, your
miss their
point is well
medication.
taken. That's a very valid point. Dr. Naseem, could you please come back on this question?
Ma'am, about the compliance is not that issue. Maybe the treatment because of the pleural effusion was not resolving. So they have extended the treatment for tubercular pleural effusion for 1 year.
No, Dr.
Because
Naseem. Dr. Naseem, what Dr. Saab is asking you, you see, because this is a little unusual type of thing. The pleural effusion was not that massive. It was a very small pleural effusion.
Yes,
And why the patient did not respond, that is a very, very unusual situation. So the question was, which also I had asked. So I presume that I asked, was it dots? You said, yes, it is dots. So the question here is, there is some doubt about the, about the the compliance of therapy. That is what also he is asking from Sagar. So can you just tell a little bit about that part? Because this is a very big issue. It's a very small pleural effusion and the patient now gone on to so much of complication. So you agit why it is so. That is the point. Was a pleural tap done? Was a, if it pleural effusion is just not a gives drugs. Any pleural tap was done, anything that is what, and the main thing obviously is compliance. What he is telling, I agree with him. That question I first raised. What about
and besides
compliance?
also, I may ask that just by seeing the pleural effusion, somebody might have started with the corticosteroid also. So was like that? Corticosteroid was also given just seeing the pleural effusion, and that was one of the reason for this type of fiasco.
There is no any evidence with us whether they have given corticosteroids or not. We have the information only about that she has taken the dots.
What about Bidaquilin? Dr. Bharadwaj had asked that question. Was any attempt made to get Bidaquilin? Can you tell that? Because
no, sir, that time Bidaquilin was not available. So
sir, the Dr. Barua in Guwahati has had plenty of Bidaquilin with him.
I have one more
Maybe
question.
some other reason why it was not available. Maybe other.
Anyway, there was some missing. You see, I mean, these are very important and pertinent points, Dr. Naseem, because you see, one thing about, I think there is some doubt about the first time compliance. Secondly, the Bidaquilin, I do not know 2019, why straight away you are telling Bidaquilin was not available. We do not know, maybe your STO can tell or any attempt was made, Anyway, I mean, that is beside the issue now. Or maybe if there is any other question, or else Dr. Singla can go how to handle this case.
I have one more question that that is not directly related with this particular lady. Actually, I am from Sagar, and here in Sagar for a very long time, from last 8 months, CB NAT is not being performed. Because
we will take that question later.
Yes.
Now with these three issues, Dr. Singla, we have three issues of compliance: corticosteroid and availability of Bidaquilin. I request Dr. Singla to take up the discussion for the case.
Yes, thank you everyone for presenting this case and for coming to some of the discussions there. So when I am I've decided to take this presentation to discuss these points which are being mentioned here in the discussion. So coming back to this case, so this was a 59-year-old female who was diabetic and hypertensive, and she was referred to difficult to treat TB clinic in July 21, and subsequently was admitted in the NITRD in August 21. Now the past history of the patient revealed that she had a history of tubercular pleural effusion and had taken ATD from May 17 to April 18. So as rightly being discussed, normally we should give only 6 months of therapy. But here we can see she received almost say 11 months of therapy. So at that time we went through the records of the NITRD because she was admitted at that time in not in 17-18 but in August 19. So it had mentioned that this was the past history which patient gave. That patient was treated under the dots, and patient said that the treatment was prolonged by the doctor, but the reason was not known to the patient. What we feel in the field, 2-3 reasons. Sometimes the patient, the doctor feels that yes, there is a pleural effusion, minimal, it is persisting, let me prolong the duration of treatment, which normally should not be done. Regarding the steroid, whether given or not, it was not clear, not mentioned in the case record, whether even the patient did not know, patient did not have any records, whether she received steroids or not. But about the prolongation of duration, she mentioned that it was done by the treating doctor. So this question remains unanswered whether steroids are given or not. But very valid question that sometimes when we give unnecessary steroids, it can predispose the patient to development of drug resistance, but that usually happens once you give steroids in a patient who is not on adequate anti-dengue treatment. So before we give steroid for any, suppose, tubercular pericarditis or tubercular meningitis, first we need to ensure that patient is on adequate anti-TB medication which are likely to be effective. Then only put the patient on steroids. In infusion, some of the physicians, they add steroid to reduce the thickening. So these are just conjectures. We do not have the correct answer for this, the reason for prolongation of treatment. And in August 19, after this April 18 episode, she was cured or she improved, we can say. In August 19, she had pulmonary TB and also had features suggestive of gastrointestinal TB as was presented in the case. Because I am just summarizing now. On 27th of August, sputum were done for gene expert, MTB was detected, and rifampicin was found to be resistant. The sputum LP immediate reports were awaited at that time in August. So she was admitted in NITRD on 29th of August 19. This was the X-ray at that time, showing the parenchymal lesions as well as pleural thickening on the left side with minimal fibrotic scars in the right chest also. Now, after the patient was admitted in NITRD in August 19, so we traced this record from the record of the NITRD because now when we are seeing the patient, it is in 2021. So anyway, we could take the records out from NITRD. So she was started on the shorter injection-containing regimen from 29th of August, which was the conventional injection-containing regimen at that time. Sputum for LP and the immediate culture were sent, both of which were smear negative, but others reports were awaited. And sputum patient also informed on 4th of September that sputum was done at a private laboratory in Assam, which was done on 27th of August and reported on 4th of September, which showed INH had high level resistance, rifampicin resistance, fluoroquinolone resistance, and secondary injectable sensitive. So normally, when we have the FQ resistance, we should stop the injection-containing shorter regimen and switch to the other drugs. But since the report was from a private lab, and most of the private labs in the country are not certified for the LPA, so the physician at that time, who were treating the patient at that time, they ignored the report, and it was there in the record mentioned, and they decided to wait for LPA report from the NITRD. And the shorter MDR-TB regimen was continued. So the culture which was done at NITRD was positive on 19th September, and LPA done at NITRD on the culture, it showed the following pattern. Because the smear was negative, so it could not be done directly on LPA, it was done on the culture. The INH had high level of resistance, rifampicin was resistant, the fluoroquinolone was resistant. But good thing at NITRD is that our laboratory always reports about the mutation pattern. So mutation pattern at that time was MUT3A present, but MUT3B, 3C, 3D all were absent. So this helps us to know that even if patient is FQ resistance, but whether we can give high dose moxifloxacin or not. With this kind of mutation, this we have been discussing in the previous difficult to treat TB clinics also, that when we have mutation MUT3B, 3C, and 3D are absent in a FQ resistant case, the high dose moxi is likely to be sensitive and we can give that. The second-hand injectables were sensitive. And the cultures of this midget and DST report, they were awaited. Now, on 19th of September, patient was, since we received the report of this LPA, the regimen was changed. The shorter injection-containing regimen was stopped, and patient was put on a regimen of moxifloxacin high dose, linezolid, clofazimine, cycloserine, pyrazinamide, and kanamycin. At that time in Delhi, during that time, the bedaquiline was not available. It is also there mentioned in the case file. That is why they had to go for a regimen without bedaquiline, in the hope that whenever it is available, we may think of adding that if felt appropriate. So now, so moxifloxacin, linezolid, clofazimine, cycloserine, these were the drugs. And why the pyrazinamide injection kanamycin was added was, in the, as you remember, in 2017 guidelines, this is the replacement sequence, consisting of pyrazinamide if sensitive, amikacin if sensitive, then other drugs, ethionamide, PAS, etc. So 4 drugs were already there, and then pyrazinamide DST was not available at that time when we were designing, when the institute was designing the regime with the treating physician. So PZA was added, and also injection amikacin because that was sensitive. So this was a 6-drug regimen which was started, and this regimen was to be reviewed after the extended DST report and audiometry. On 21st, the audiometry report came that patient had abnormal sensorineural deafness. She was 59 years of age. So thinking that the injection kanamycin was stopped, and this was replaced by ethionamide. And if you remember, the INH was only high dose INH resistance, low dose was sensitive. This again indicates once low dose INH is sensitive, it indicates that ethionamide may be sensitive. So, from these kind of report from the LP, LP, how much it can help us. LP can tell us whether both low dose as well as high dose moxie is sensitive or not, whether low dose moxie is resistant but high dose moxie can be given, whether ethionamide can be given. So we have been requesting through this DTDC to all the laboratories that they must report the mutation pattern and also the interpretation of the mutation pattern that physician can use these drugs. So that is very essential for proper management of the case and proper selection of the drugs. Subsequently, the patient was discharged on the regimen moxie high dose, linezolid, clofazimine, cycloserine, along with pyrazinamide and ethionamide. Now, extended culture DST report which was to come, which was sent in September. This report came after 3 months, and it showed ethionamide resistance, pyrazinamide resistance, levo resistance, and moxie 0.5 at that time. 0.5 was indicating low dose moxie. It was resistant. So at that time, 0.5 was low dose and 2 microgram was high dose. And today, 0.25 is low dose and 0.1 is high dose. So since this is being talked about this 2019, so that was the low dose. And patient was sensitive to moxie high dose, linezolid, clofazimine, PAS, and injection. They were sensitive. However, you see, this report came after 3 months. By that time, patient had gone back to Assam, and somehow, this is again, this report was missed, and no action was taken on it. Again, this is another field issue that whenever we start a patient on a particular regimen based on the LPA pattern, and we decide that okay, it will be reviewed by the culture DST or the extended DST later on, we have to really follow it up. It is the duty of the concerned the district to keep a track of this. The entire district team, whether DTO or STS, the STLS, STS, all the people, they have to note somewhere that we will be reviewing the regimen after this. But unfortunately, the report was, no action was taken on this report. So as a result, from 21st of September to February 21, for these 18-20 months, patient continued on moxie, linezolid, clofazimine, cycloserine with ethionamide and pyrazinamide, although they were resistant, as we just discussed. Now, in February 21, I think the report must have been there, and they stopped pyrazinamide and ethionamide. So from February 21 to middle of the May, patient was on moxifloxacin, linezolid, clofazimine, and cycloserine. These 4 drugs, and I'll come to in the next slide because she continued to be sputum positive. So in May it was stopped, and from May to August the patient has not been on a medication. So this shows in January and February 21 the patient had been culture positive and again showed pyrazinamide being resistant and sensitive to moxifloxacin, linezolid, clofazimine, and cycloserine, and in moxie, that is even low dose it showed. So then we really have to recheck about this. On 17th of June, this patient had ECG with right bundle branch block and QTC-B, that is QTC Besser, showing 493 milliseconds, which was again a worrying factor for the treating team in Assam. In July 21, patient had uncontrolled diabetes with serum creatinine 1.5 milligram, which again indicates if you calculate based on the gender, age, and the creatinine levels, the GFR of 35 ml per minute or 1.73 indicating moderate renal failure. And these were the X-rays shown earlier by Dr. Naseem. So as we can see, serially from January to May to August, patient is deteriorating radiologically. So patient was referred to difficult to treat TB clinic in late July, and patient had taken the second line drugs for almost 20 months. And with moxi high dose, linezolid, clofazimine, and cycloserine, they are still sensitive 2-3 times, but patients continues to be culture positive and deteriorating also. And the other comorbidities which they had mentioned in the DTTC form was that 17 June patient had this high QTCP, and July patient had a high creatinine rate. So these were the issues with which the patient was referred to the difficult to treat TB clinic. Now subsequently patient, because her daughter is in Delhi, they decided to come to Delhi, and they were admitted in NITRD on 9th of August. So sputum was done on LP was done on 2nd of August, which showed MTB detected. INH, rifampicin and fluoroquinone high level resistant. The second injectable sensitive, and extended DST report awaited. The pre-treatment evaluation at NITRD showed anemia weight from 9 grams, so 1 unit of packed cell and oral iron were given, and follow-up hemoglobin was improved to 9.9 grams. Calcium was 8 milligram and put on oral calcium supplemented. That was started. In July 21, patient had uncontrolled diabetes with a serum creatinine of 1.5 milligram. But on admission at NITRD, it had come down to 1.07 milligram. And as we'll see, subsequently on 14th of August, it had further reduced to 0.77 milligram. And the pre-treatment evaluation further showed that on 17th of June, ECG had a right bundle block with a QTC VESAT of 493 milliseconds. So we retrieved the ECG, and we found that heart rate was 79 and QT interval was 430 milliseconds. So using an app, I'll come to that. It showed QTCF, that is QTC Fredericia, of 471 milliseconds. That 493 you have to act, you have to do the electrolytes, and if electrolytes are normal, you cannot give the cardiotoxic drugs. But at QTCF for 471 milliseconds, one can continue with monitoring. And on the day of when started the bedaquiline, it had come down to, the QTCF come down to 430 milliseconds. And all other investigations were within normal. So here before proceeding, I think I want to reiterate about several, some of the things about the QT prolongation. You see, we all know the drugs which can cause QT prolongation include bedaquiline, fluoroquinolone, clofazimine, delapanid. These are the anti-TB drugs which can lead to increase in the QT interval. And we measure it from beginning of the Q wave to the end of T wave. And we always need to correct this QT interval for the heart rate. And there are various formula for this correction. One is the Bézard formula, QTB. Then we have Fredericia formula, we have Framingham formula. So in the chest practice, usually it is the Bézard formula and the Fredericia formula. The issue is that most of the ECG machines in the country, including all the Chinese machines, including the BPL machine, which is very popular in the country, they are giving reading as per the Bézard formula. And usually this Bézard formula is much higher than the QT Fredericia formula, especially when the heart rate is high. But for the clinical management of this drug-resistant TB cases who are put on this cardiotoxic drugs, we need to see the QTCF. That is, we need to see the QTC Fredericia, not QTC B. And for the QTC F correction, if it is more than 450 milliseconds in male and more than 470 milliseconds female, we call it that it is prolonged and they are at increased risk of developing the cardiac arrhythmias and like tortuosity points, which can be life-threatening. So to take care of this, what has been done? Like you look at this ECG, and it is small. Here the heart rate is. This is done by given by all the ECG machines. They give heart rate that is 104. QT interval is 389. And on the top you can see this app. You know, through this app, if we have these two information of heart rate and QT interval, we can feed in this app. I'll show that, and we can calculate the QTC Fredericia. So in this case, QTC B, which is shown on the ECG also, is 513 milliseconds. That means 530 milliseconds means more than 500. Immediately stop QTC prolonging drugs or do not start the QTC prolonging drugs at that time. So, but before acting on that, we need to know the QTCF. So this is the app where we feed in the QT interval, which was 389. The heart rate was 104. Then we choose the formula and press calculate. So the corrected QTC interval. So here the QTC-B was 513, but when we fed the heart rate and the QT interval, QTCF was just 467. So that means it was almost normal. So the idea is that we must, before reacting to any QTC-B or any QTC mentioned on the ECG machine, which is the QTC Bassett, we must calculate the QTCF and then only proceed for the clinical actions. And you know, this thing was noticed by our institute in earlier part of the introduction of bedaquiline in 2017-18, that we were having, like for example, this case, the QT interval showing 506, which was actually Bassett's. And when we calculate the FRDC, it was 456. So difference of 50 milliseconds. Another case, 495 and the QTCF 450, so difference of 45 milliseconds. Difference of 45 milliseconds. So then we consulted other institute also who are using this. They also found the similar differences. We brought it to the notice of the Ministry of Health, Central Division, and it was agreed that no, we must calculate using the map, the QTCF, and then only act on this. And we also should know whenever we are treating these cases with the QTC prolonging drugs, that there are certain high risk factors which can lead to QTC prolongation. They include dyselectrolytemia, like low levels of potassium, calcium, magnesium, renal failure, hepatic failure, malnutrition, diabetes, thyroid dysfunction, underlying heart disease. In case this is risk factor, the risk factors are not there at the baseline, and we find the QTCF is less than 450 milliseconds in males, less than 470 milliseconds in females, then as per current guideline, there is no need to admit the patient. Just perform the ECG at the baseline at 2 weeks and then at monthly intervals. So provided these risk factors are not there. So again, as you can see, it is very important to ensure that before you start in the pre-treatment evaluation, even the electrolytes should be within the normal range. Another issue in this case was when she was referred was that she was having high of 1.5 milligram, but fortunately, subsequently we found the creatinine levels were 1.07 on 9th of August, and 14th it was 0.77 milligram. And there are various formulae for calculating the you see also you know some people feel that suppose the normal range is up to 1 milligram, it is normal. No, we have to calculate the glomerular filtration based on the base.
We request Dr. Mahesh to please, Dr. Mahesh MG, to mute his device. Thank you.
So we must calculate the GFR for the clinical actions. That depends on the age of the patient, the serum creatinine, and the gender. We should not feel that it is 1.2 milligram, it is normal, or 1.3 is mildly raised. No. We should calculate the glomerular filtration rate, and various formula, and this is one of the formula which I mentioned. And we also should know that whenever we are treating the drug resistant TB cases or even TB cases, there are some of the drugs which require a change of dose, some of the drugs do not require a change of the dose. So for the drugs which require a change of the dose when the GFR is low, they are ethambutol, pyrazinamide, injectables, levofloxacin, cycloserine, and PAS. And the drugs we do not need a change in the dosage. They include moxifloxacin, bedaquiline, linezolid, clofazimine. So you see most of the group A and group B drugs they do not need. Delamidate and ethionamide also do not need the change in the dosage. So these factors also we need to keep in mind. And how I remember is that moxifloxacin, if you see, is safe for kidneys but unsafe for heart. On the other hand, the levofloxacin is safe for the heart, comparatively safer for the heart, but unsafe for the kidneys, requires a change of dose. So these basic things one need to keep in mind, because in this case that these issues So in between, I brought out these two issues of QT prolongation as well as the renal toxicity. Now coming back to this case. So in August 21, with all this information we had, so the following plan was made by the NITRD prior to the admission that the sputum widget culture and DST will be sent. In this case, because despite taking the drugs and as informed to us by the Assam team that she had a good compliance. So despite a good compliance, despite a good regimen, and remaining still remaining the culture sensitive and also remaining the sensitive. So that means there is in these cases even poor absorption of the drugs has to be suspected. Once you ensure the compliance and you feel that patient is sensitive to all the drugs and still the not responding, the culture remains positive, that means clinically patient is failing. So we also plan that we will do the therapeutic drug monitoring. And patient had already taken moxifloxacin high dose, linezolid, clofazimine, and cyclosin for 20 months. And now even the moxi high dose was resistant, and the rest were sensitive. So keeping these factors in mind, you see, as per basic principle of designing a regimen, that is that you look at the laboratory reports, you look at what drugs patient has taken, what drugs patient has not taken, and then add at least 4 new drugs which are likely to be sensitive. Likely to be sensitive means patient has not taken them, or the laboratory is saying it is sensitive, or in that country the resistance to that or these drugs is low. So based on these principle, you feel that these are the drugs which are likely to be sensitive. For this case, so 4 new drugs were bedaquiline, delamanate, PAS, injection imipenem, celastatin, supplemented with amoxicillin and clavulanic acid as the guidelines are, because that we give this with imipenem. And linezolid and clofazimine, they were retained since they were laboratory was saying they were sensitive, so that we could support the regimen. And linezolid we decided to give in injection form. Why? Because among in this regimen, if you see, this was the only drug which is available in the market in the injection form, and we were suspecting poor absorption of the drugs. So we decided that till we have this drug monitoring report and till we have the extended culture DST report, we will be giving so the regimen which was decided for this was bedaquiline, delamanate, injection linezolid. I explained why. Clofazimine, PAS, injection imipenem, celastatin with amoxicillin, clavulanic acid after admission. The PIC line was to be inserted because we had planned to give injection imipenem, celastatin, and as you all know, this has to be given by the IV route. It takes about 1 hour in the morning, 1 hour in the evening, because we give 1 gram in the morning, 1 gram in the evening. So, and the cardiac, the therapeutic drug monitoring to be done, and cardiac consultation in view of the query prolongation of QTC and the right fundamental. So this was our plan. So admitted on 9th of August after the pre-treatment evaluation, cardiac consultation was done, and she was advised to be started on the bedaquiline containing regimen, because even they found that the QTCF was not prolonged, and with monitoring of the ECG and electrolyte. And in view of she also had renal issues, so it was decided that we should be done under strict monitoring. Ophthalmological examination was done, which was within normal limits, and the PIC line was inserted after admission on 12/8. You see, these things take time. So mid on 9/8, so we cannot. Ideally speaking, we should do everything in one day, but you know we have to send the patient out to get the PIC line. So everything takes time. So this was the. If you, I hope you can see the PIC line is there. This is the PIC line which is there. So that was inserted. And on 14th of August, the following medications were started as per the body weight. The injection imipenem, bedaquiline, omoxiclav, linezolid injectable form, clofazimine, delamanate, and PAS was not available. Even delamanate, you know, it could be added only on 19th of August because earlier it was not available, and really we had to we wrote to the DDGTB. We thank DDGTB, Dr. Ravinder as well as Dr. Sanjay Mattu. They all helped in arranging one course of delamanate for this patient. So it was delayed to 14 because we wanted to start once we had majority of the drugs with us, but it took time. So at least on 14 we could start with the drugs mentioned here. PAS we are trying. I will come to that later. and delaminate could be arranged on 19. As you all know, in the entire country there is shortage of delaminate, but fortunately, by the efforts of the DDG-TB, Dr. Vinder and Dr. Sanjay, it could be arranged. And while on these medications, she had few episodes of vomiting, which were managed with the antiemetic metoclopramide. It is safe to be given with bedaquiline. Repeat kidney functions, electrolytes, they are being followed up and they are within normal limits. On 24th of August, creatinine is 0.77 milligram, and the ECG monitoring is being done daily during this admission. And you can see this is all QTC-F, because we always take clinical action based on QTC criteria. As you can see, they have been normal. On your 23rd, we found that QTC-B was 490 as given by ECG machine, but QTC-F was 480 milliseconds. So up to 480 milliseconds, we just have to monitor the ECGs and the electrolytes, and no need to stop any of the cardiotoxic. And these are the like this is the ECG which had shown 490 milliseconds QTC-B, but on calculation QTC-F is 480 milliseconds. So patient completed 14 days of therapy on 27th of August 21. Extended DST report which we had sent on 2nd of August was available on 5th of September. It was registered to pyrazinamide, ethionamide, levofloxacin, and moxihydro. So same pattern as before, but sensitive to bedaquiline, because fortunately at NITRD we are doing the DST to these newer drugs. So bedaquiline, delaminate, linezolid, tofazamine, and PAS, they were all found to be sensitive. So in view of this extended DST report, we decided to continue the same regimen. PAS is not available, and we are making efforts to arrange it. And now I'm told that we have been contacting various drug companies, and within a few days, maybe by early next week, we'll be arranging PAS also. And blood sample you see regarding cerebral drug monitoring, because that was our plan. It was sent to Chennai on 8th of September, but it got spoiled on the way as it took long time of 3 days. We sent it with the dry ice, but it got dried up. And let me tell you, we have been doing this cerebral drug monitoring for last 6-7 years, almost 70, 80, 90 patients we have done this. And but sometimes during COVID time also we could not do it because the issues of the availability of this courier services. And in this case also the sample was found to be spoiled there. And we thank the NIRT for supporting for our TDM, and they are able to do the TDM for bedaquiline, delaminate, linezolid, cycloserine, levofloxacin, oxyfloxacin. But in this case, as you know, the oral drugs are bedaquiline and delaminate. So we have requested them to, we'll be sending sample early next week itself, and to do bedaquiline and delaminate to inform us what the levels are. Linezolid patient is on injection, so it's not much of use. And cycloserine patient is not on. Even levomoxy patient is not on that. So looking at the current regimen, we'll be interested to know the therapeutic drug levels of bedaquiline and delaminate. Now the patient till 21st, patient has completed more than yesterday, more than 5 weeks of therapy. The patient is clinically stable, and further plan is to continue the same regimen. And the past tablets we have been told by MacLeod company they will be arranging within yesterday only we talked to them, and by Monday itself they said it will be arranged. And we also plan in this case, because if you see, once we stop bedaquiline delaminate at 6 months, in that case we will not have a good regimen with us. So we have planned to extend bedaquiline delaminate, and we will be doing the culture and DST every month. And depending on that, we'll be taking an action, but we are open to extend bedaquiline and delaminate. And patient will be followed by culture, semogram, kidney functions, and ECG monitoring. So that's how we are planning in this case.
Okay.
So, dear all colleagues, through this case, I want to share some take-home messages. First is that we must follow the principles of making a regimen, keeping in mind what drugs patient has taken, what drug patient has not taken, the DST pattern, and in case we are not able to have a classical oral longer regimen, then current replacement sequence we have to keep in mind to replace the drugs. We should take the clinical decision based on QTCF and not based on the QTCB. In that case, sometimes we may be unnecessarily stopping the good drugs, misinterpreting as that they are cardiotoxic. And another thing which we found was that non-action on the culture DST report. So we must track the sputum culture DST report if it has been sent, and whenever available, we must take action on this. We should try our best to arrange the TDM if poor absorption is suspected. And till that time, we should give the drugs in the injection form, whichever drugs are available in the injection form. Unfortunately, very few drugs are available in the injection. The bedaquiline telomerase may need to be given for 6 months on case-to-case basis. Like in this case, we feel there may be a need, so we are open to that. Make full effort to arrange the drugs which are not available. Like in this case, by the efforts of every month, the telomerase 1 course could be arranged. And never leave hope, keep on trying, and in case you are cornered, you must consult the difficult to treat TB clinic if you feel there is a need for this. We are all here to help you, to help our colleagues in the country. Thank you all. Thank you very much.
Thank you, Dr. Singla, for a very good discussion on the case. We are now joined by more than 320 spokes. We have Dr. S.K. Sharma. Thank you, sir, for joining us. Dr. K.K. Chopra and Dr. Alpa Dalal from Mumbai, and other state TV officers who have joined us during the course of this case. So as you all know, this was a case of a 59-year female from Assam who had other comorbidities and was on DRTB treatment since 2019. And this patient was referred to NIDRD for management, and Dr. Singla gave us some steps as how it was managed at NITRD. So now there are questions on the chat, Dr. Singla, if
Yes,
you permit
please.
me, and Dr. Mehra, sir. If you permit me, we will take up the questions first, which are sent on the chat. And if still there are some questions, we will ask the participants to raise their hand to ask the questions. So I request Dr. Amitesh, my colleague, to take up the questions, and we will divide questions into diagnosis, treatment, and operational issues for clarity. So first, we will take up questions which are pertaining to diagnosis.
Right, ma'am. There are few questions pertaining to the diagnosis, especially relating to ethionamide resistance, as it was in this case. So there is one question which has been asked that in this case, INHA was absent, but still the phenotypic DST showed ethionamide resistance. So is there any role of EDHA mutation which can be responsible for this?
Yes, you see, it is I agree on that point. And also when we talk to our microbiology colleagues, they always say in case mutation to INHA is not there. So always you give the benefit to the patient thinking that ethionamide could be sensitive. In case INHA mutation is present, then you take it that the ethionamide is resistant. Of course, we always do the DST, but in this case, they say this mutation is so strong that in case it is present, even if the lab is saying that the DST is saying ethionamide is sensitive, then you treat the patient as resistant in the interest of the patient. And the other mutation mentioned that also has a role in few cases. That's why you see there are discrepancy between the genotypic and the phenotypic test.
Then there is another question pertaining to this ethionamide resistance, that what is the reliability of phenotypic DST of ethionamide?
So that I already answered in this. Otherwise, reliable, but whenever you find the genotypic tests are suggesting it is there is a resistance, we should not give the ethionamide to the patient in his interest. We should give benefit to the patient and not give.
Thank you, sir. Then now there are certain questions pertaining to the treatment part. One question by Dr. Yatin. He asked that was shorter MDR-TB regime justified in this patient who was previously treated with ATT and has diabetes as a comorbidity?
You see, if you look at the contraindication to the shorter regimen, even at that time, patient just had a pleural effusion. So history of pleural effusion is not a contraindication, or even diabetes is not a contraindication to start the shorter injection continuation. So the patient did not have the fluoroquinolone resistance at that time when patient was given this. So broadly speaking, there was no obvious contraindication to the shorter regimen. Like extensive disease was not there. The extensive extrapulmonary disease like CNS TB, meningeal TB, they were also not there. The FQ was resistance was not there. So in that situation, the shorter regimen was justified, I feel.
Right. Thank you, sir. Then there is one question by Dr. S. Das, that can NTM be a cause of deterioration in this patient despite the patient worsening on second line drugs?
Very unlikely, because whenever you do the culture and you do DST, all the laboratories as a routine, after the culture, they do the identification, whether MTB or MOT. In this case, it was MTB present. So once MTB is present, the NTM is ruled out, because that is done routinely. And they mentioned MTB present. Even the genotypic test, this is for information to all, that in case it is NTM, the genotypic test will not be positive. The CVNet will not be positive, LK will not be positive. So in a smear positive case, in case you find the gene expert is negative or the LP is negative, then you think of the NTM. But in case it is positive, then the NTM is unlikely.
Thank you, sir. The next question by Dr. Vikas Oswal, sir, that what is the significance and reliability of doing TDM of second line drugs?
Yes, like in this case, you see, this we had been debating. Like she was on second line drugs, sensitive also, but still was not responding. And now we have made a regimen again containing second line drugs. So we are really not sure whether this patient is absorbing the second line drugs also or not. So in that scenario, it is always better that we do the TDM while patient is on the second line drugs and prove that the levels of the second line drugs are within the range which it should be in case she is absorbing the drugs. Because we should not believe that only the first line drugs will be affected in case patient is having poor drug absorption. Even the second line may not be absorbed in case some patient has a poor drug absorption.
Thank you, sir. Then there is one very important question by Dr. Nanda. He gives a reference of a case of a tuberculoma brain where bedaquiline was advised beyond 6 months. So can bedaquiline and delaminate be given beyond 6 months?
Yes. Now you see, even if you see the WHO guidelines, you see the national guidelines 2021 on a case-to-case basis, there have been the indications have been defined when we can prolong the use of bedaquiline, when we can give them together. Like for bedaquiline, it can be prolonged to more than 6 months in case you find that not more than 2 drugs are available from group A and group C. If you find at the end of 6 months, if you stop bedaquiline and other drugs, then you will not be having more than 2 drugs from group A and group B. In these cases, one should consider extending the BDQ. And in this institute, as I found somebody is asking up to how long, in this institute, because we were a part of the salvage regimen research project also, where we had cases who have no other hope. They have been given many of the second line drugs, and we had put them on bedaquiline, delaminate, and the other uncommon drugs like injection, upinam, etc. In some of the cases, we had gone even beyond 12 months. And even the international experience has shown that there are some of the case reports where they have given it for 12 months, 18 months also. But again, this should be on case-to-case basis. They should not be taken lightly, and patient need to be monitored by the ECG, by doing the cultures, and by the electrolytes to see that we are on the right track and there is no toxicity to the blood.
Thank you, sir. Then there was a question by Dr. Brahm Prakash. He wants to ask that whether ibipinam and PAS was still needed in this case, as the patient was already on 4 sensitive drugs: bedaquiline, delaminate, linezolid, and clofazimine.
You see, linezolid, but patient had been taking. Patient had been taking the linezolid clofazimine. So in that case, it could not be relied upon as a good drug. Once the patient has been taking a drug, and even if it is sensitive, we cannot rely on its action. So minimum 4 drugs we need to add, and even in view of the poor absorption also, we are not very sure whether the oral drugs will be absorbed properly. So that's why we felt we must supplement this. And this is the last chance what you are giving to the patient. In case this regimen fails, you all will agree that there is nothing we can offer to the patient. So keeping these 2 things in mind, that poor absorption of the oral drugs cannot be ruled out. Linezolid patient had taken earlier, although sensitive, but patient had taken earlier. So it was a drug on which you cannot rely that this will be effective drug. So we had to add this.
Thank you, sir. Then there is one question by Dr. Yatin. He wants to ask, what is the role of home genome sequencing in diagnosis of these cases, in these difficult cases?
Yeah, it is the whole genome. WGS has especially has a role, once we find there is a discrepancy between the genotypic test and phenotypic test, and also some unknown mutations which are not caught by the genotypic test, that can also be caught by this. So it can help us in knowing the resistance pattern in these cases. But here you see issue is 2, 3, 4. One is the resistance pattern, which our lab is already telling us. The absorption level is there. Then there are issues related to the QTC prolongation. That patient may not develop QTC prolongation. Yes, WGS can be added, but will not have much role in this case.
Right. Thank you, sir. I think that's all the questions which were on chat. If anyone wants to ask the question, he can unmute himself and can ask.
Now that no one is raising their hand, I thank Dr. Vikas Oswal, Dr. Jaykishan, and Dr. Yatin Dholakia for joining us. And now I request Dr. Behra sir to give his expert opinion for the case.
So thank you, Nita. And again, very good afternoon to all of you. I could see a lot of, very senior chest physician, chest TV specialist are there. And I think Dr. At the outset, I must congratulate Dr. Rupak Singla very nicely discussing and analyzing the case point by point. And some of my queries, in fact, were already taken care of. I'll just like to give 3 or 4 broader comments in the national context. The number one, again, I'll go back to, ladies and gentlemen, to the first diagnosis of pleural effusion. I'll still like to rake up that issue. Have we missed a case of pleural effusion which was MDR to start with, some drug resistant to start with? Because I think the question was already raised whether we presume that it is a drug a sensitive case and he was given treatment, why it went on for 1 year, and why whether steroid was given, not given. So these are some of the issues. I'm sure NITRD must have got the treatment card. I think we need to go into that detail. That means possibly it was because I am sure the pleural fluid gene export testing was not done, might not have been done. Again, these are all theoretical questions, but I think that is again what I am trying to emphasize is that we should also be careful. It may be possible that from the very beginning we are handling a case of MDR TB of the pleura, and maybe which went on and on the subsequent issues. Then the number 2 point, which I noted that I think 2 times Nasib told that there are mixed reports. That is again a very serious issue, and I think as the clinicians, whoever is handling the cases, whether it is at the the STO level, DTO level, or even at the medical college level, there should not be things like missed reports, because these are precious samples, precious reports. So we should not have a situation like this. There was a missed report. He said it could not be traced. I do not know why it is so. And the third important point, which Professor Singla also highlighted repeatedly, you see how important is the DST test, and that based on many things. So I think the importance of, in a way, it was individualized treatment here in this particular case. So I think we should be very, very careful about the lab reports, getting them. They're very precious. Then that raises the point of the private lab. I do not know why a patient from the, what is the role of private lab at this stage, but at least whatever private lab report was done, that was almost for the first time, it was tallying, it was tallying with our, so what is the role of that and how the program is going to that? I am sure that is a point to think, but of course, subsequent things which was done at NITRD, the private lab could not have done that. So private lab has got a role to certain extent. Then obviously the comorbidity in this case, as the diabetes, I think Dr. Singla, you will agree that all our recommendation or whatever experience we do not have an exact answer how these our recommended regimens do with the comorbidities, particularly conditions like diabetes, and more so in this case the diabetes itself was uncontrolled, as Nasim has told. So I think the simultaneous treatment of the comorbidity conditions is also very important. And at the last, I'll just make one comment. Maybe Dr. Singla again will like to come back. So it was obviously a individualized regimen which you have decided at the end, right? Am I right? Which you people do, and when everything fails, so we go for individualized treatment, and the same was done here. I do not know what will be the outcome. And what about the BPAL regime? Suppose, say for example, we have got BPAL available. What do you think? Do you think BPAL would have been a was a choice in this case, because it is a difficult to treat MDR case. It is a pre-XDR case now. So what will be the role of BPAL? That will be my question to you, Dr. Singla. Can we do that if it is available? Of course, it is not yet recommended or not yet approved for our country. And then the last point about the TDM, I think somebody had asked a question about what is full form of TDM, that is therapeutic drug monitoring. I think that is again an important issue, that the various anti-TB drugs, their therapeutic drug label, it is at present, it is only NIRT is the only one who is doing it. I am sure I will request now, it is now the DDG-TB, I am sure he will be there, and even Dr. Diwan will be there, and Dr. Rupak, you are there. I think the therapeutic drug monitoring is an important issue which the program should think very positively and more seriously, not only for these newer drugs, it is also our standard drugs. So those therapeutic drug monitoring are also not available. So ladies and gentlemen, I am again, thank you very much, Anita, Rupak, and Dr. Diwan for, for inviting me as giving some specific comment about this case. So I think these will be some 4 or 5 my important comments. So thank you everybody. Back to Nita.
Thank you, sir. Thank you for your comment. Just briefly, I'll touch upon the 2-3 things which you have asked me to respond to. One is the TDM, sir. I think you have mentioned very correctly. We all feel the need that we should have at least in each state access to the TDM, because collecting the sample and sending them is always a challenge we have been facing, and sometimes on the way it gets spoiled. And also there are many cases in each state, I am sure, which need therapeutic drug monitoring. Even at our institute, we have talked to. We have talked to our director, Dr. Diwan, and we are also looking for it, the possibility of starting the TDM in our own institute. And even the ministry level, they should make efforts to have such laboratories which can carry it down on a reliable basis. Even so, regarding the LP from private, somehow I'm finding that from the Northeast, they have challenges in getting the LP report on time. And many patients from the program, they are being referred to private lab for the LPA. And we know most of the private labs are not certified to carry out the LPA. So physician must be in dilemma whether to respond to these LP reports or not. In this case, it matched whatever was done in a tertiary institute. So we have to request all the program people that try to send them as early as possible to the IRL which are nearest to them, and try to have early reports so that action can be taken. Coming to sir BPL, the BPL regimen. In this case, for the BPL regimen is when for the XDR patient or for the MDR TB treatment failure patients. And this was we can say a treatment failure patient. But patient will not be eligible for BPL because for BPL because patient has taken more than 2 weeks of linezolid. So one of the criteria for BPL is patient should not have taken the drugs in the regimen for more than 2 weeks. Whether it is bedaquiline or predominant, of course, is not available in the country as of now, or linezolid. So if anybody has taken more than 2 weeks and this patient had taken lenazole for more than 2 weeks, so VPAL even today cannot be considered for this case. That's from my side. Thank you again, sir, for guiding us and for your valuable comments.
Thank you, Dr. Dera sir and Dr. Singla. So the take-home message, there are two hands raised, Dr. Kinjal and Dr. Soma. We'll take a quick question from you if you have. If there's a burning issue that you want to ask.
Yes, ma'am. Regarding, there is a small question to Singla sir. The presentation is as unique as always, sir. Present very nicely and thoroughly. We always face the problem that there is always a delay in the culture report and DS report coming to us or to the patient. So can anything can be done programmatically? Can something can be done as a program person, because Singla sir knows the program way better than anyone else? Can something be included in the program so that this kind of missing reports can be avoided in future? At least whatever best can be done.
Definitely, the one main point is the line listing. Whenever you have started a patient on a empirical regimen and the report has been, and you have multiple patients in a district, so you have to maintain a line list that in this case the DST report has to be there. What we have seen, the laboratory they do the test, even they somehow they put the test on the limb also. That is the site where they put the test, and the DTO or their team may fail to download the report and act on it. This is the commonest reason which we are finding. So the each DTO and his team have to maintain a line listing of the patient of whom the DST report is awaited, and then download this and act on it. So that is the way to take care of it.
Thank you, Dr. Singla. Dr. Soma.
Yes, madam. Sir, thanks for wonderful presentation, sir. My question is other than this patient, sir. One of the patient was started an all-oral shorter regimen. After 1 month, patient developed anasarca, edema throughout the body and legs pitting edema. All LFT, RFT, electrolytes, ultrasound abdomen, everything is normal. Even echo is normal. We don't know what to do, sir.
Yes, sir.
Okay, Dr. Soma, definitely your question has validity. Can we discuss it separate, because this is not directly linked to the current case?
Yes,
can
sir.
we discuss it separately? We can send a mail and we will.
Okay, sir. Okay, sir. One more thing, sir. I have
You have
2,000 sachets of pass. It is expiring in 2022, sir. If you want, we can transfer from the state, sir.
Okay, okay, sure. So we'll contact you. In the chat, you please give your this Dr. Soma from NIR from NTI Bangalore.
Not, sir. Rajiv Gandhi.
Okay.
Sir,
so you please send your email and the phone number on the chat. We will contact you.
Yes,
Thank
sir.
you so much for that.
Thank you, sir.
Thank you, Dr. Soma. Dr. Rishi?
Yeah. Sir, thanks, ma'am. Sir, and sir, it's a very nice presentation, because this case is related to diabetes also. Sir, my concern is that diabetes also prolongs the smear and culture conversion as compared to a non-diabetic person. Is it true, sir? And other question is that this poor glycemic delay in this prolongation of TB, sir.
Yes, it is correct. Now, Dr. Rishi, thank you for.
Hello,
this.
sir.
Yeah.
Hello.
Yeah, we can hear. Can you finish?
Hello.
We can hear you.
Sir, am I audible, sir?
Yes, yes. Yes, you are audible. Can you hear us? Okay. So, like it is known now, there are systematic reviews on this. The diabetes, uncontrolled diabetes specifically, can lead to delay in the sputum conversion, culture conversion. It can lead to higher risk of failures and even relapses. So definitely, whenever we are treating, we have to maintain the euglycemia. We have to have a good control of diabetes to have a good outcome. That goes without saying. This Dr. Behra also highlighted, and you are also highlighting on this point.
Sir, my next question is that because we also having this UPDTC clinic also, if we are following oral PMDT guidelines of 2019, and of that case, say the cases have a long history of tuberculosis, and this now the regimen has to be modified now. So as per the we have to start the regimen as per the 2019 guidelines or as per the 2021 guidelines from for this the modified regimen which we have to start now.
Yes. So in 2021, definitely you have to follow the replacement sequence of 2021 guidelines. Only issue is, unfortunately, the first replacement drug is Delamanid. And Delamanid is currently not available in the country. So
Yes,
that is the challenge we are facing. So till that time it is available, we can go to the next replacement drug, that is amikacin if sensitive, then pyrazinamide if sensitive, like that, then comes ethionamide pass, etc. So, but we must follow the 2021 guidelines as it is based on the experience and the literature review that today these should be the replacement sequence.
Thank you, Dr. Singla.
Thanks.
Now I would close this case. The take-home message by various discussions by our experts is that we have to look into the compliance of the treatment, which is most important. Secondly, a timely management based on DST reports. So we have to send them timely. The timely cultures have to be sent. We should maintain a line list, follow these reports, and implement these reports. As soon as we get them, we should modify our treatment according to the reports that we get from the lab. And then regular follow of all the DRTB patients is very, very important in the field by our DTOs. Our guidelines also very clearly mention that all the DRTB patients should be seen at least once a month by the district TB officer so that no major thing is neglected for the patient. So we should be looking them for adherence for their DST reports and other things. So with that, I close the case, and now I request Dr. Ashok Bharadwaj, Chairman NTF, to give his closing remarks. Sir, just to let you know, apart from the senior faculty who joined us, today we had representations from state of Bihar, UP, Sikkim, Assam, Calcutta, Tamil Nadu, Jaipur, Goa, Odisha, Kerala, Jammu, Kashmir, and Telangana. And then we have representation of team from GHTM, who are also going to be the COE of Tamil Nadu. So we have all these teams who have joined us. Sir, over to you for your closing remarks.
Thank you. What was the attendance from Gujarat?
I don't see anybody from Gujarat, sir.
Okay, I had requested them, particularly requested them and the Rajasthan people to please join in. So thank you, Nita, for giving me a chance. So first of all, I must thank Dr. Digambar Behra, who brought NTF on board for this national clinic for difficult to treat cases. So thank you, Dr. Behra. So I also thank Dr. Rupak Singla for in detailed discussion about this case, which was brought by Dr. Saikia from Dibrugarh. So I think it is the responsibility of all nodal DRTB centers, the district DRTB center and STDC center to please join this difficult to treat case every fortnightly or whenever it is conducted. It is very, very important. So I want to bring about only two comments here. One is we have to provide all sorts of medicine to the patient. The DTO, concerned DTO or the concerned state TB officer has to come in between and provide procure the medicine and provide to the patient. So second is we have to focus on turnaround time for the testing, availability of result to the physician so that the treatment regimen can be started on time. So thank you, Dr. Singla Kopal, for nice discussion and all the participants, because today it was a very healthy discussion and hope so that this will continue in future also. So thank you, everybody.
Thank you, sir. Thanks a lot. There is a poll floated on your screens. Kindly take up the poll, answer the questions. It will guide us for our next sessions. The next session is next month, and we are going to have a case from Mumbai Nodal DRTB Center, and we have a Mumbai team with us who will be taking up the clinic next month. I thank everyone who joined us, all the state TB officers, district TB officers, medical officers, faculty from all the medical colleges, faculty from NIRT Chennai and NTI Bangalore, and all the senior faculty who join us every month and support us. Thank you, everybody. Thank you for joining us.
Ma'am, hello.
Yes.
Ma'am,
Yes,
I am DTO Walier. मैम हमारे पास ऑल ओवर लॉन्गर पे दो तीन पेशेंट हैं, फीमेल पेशेंट, नियरली 17 इयर्स ओल्ड एक है और एक 21 ईयर ओल्ड है, बट दे आर फीलिंग सो मच पेन इन देयर लोअर लिम्ब, not pertaining to joint, whole limb they are feeling pain, and they are I am giving them 200 mg pyridoxine, still they are not relieved. So ma'am, what could we do for them?
Yes, Dr. Seema, thank you for raising this. But first thing is that most likely this is a linezolid-induced neuropathy.
Okay, sir.
In this case, and the pyridoxine does not help in linezolid-induced neuropathy. So first thing is we must stop linezolid immediately. In case they start having this sorry.
इसका टैपर्ड कर दिया था सर, 300 mg कर दिया था इसको ध्यान में रखते हुए, पर उससे रिलीव नहीं हुआ, तो
मैं उसी में आ रहा हूँ. Even in these cases tapering के बाद भी अगर persist कर रहा है, we should not wait for longer time. We always, the moment we find even after tapering for say 5, 6, 7 days, it is persisting, because in case you do not stop it, this will lead to irreversible peripheral neuropathy because there is axonal degeneration. So people who are on linezolid, in case they start having this, we have to act early. तो इस केस में आप जल्दी उसको अभी फिलहाल बंद कर दीजिए. Then there are symptomatic treatment in the form of amitriptyline है, फिर ये pregabalin है, methylcobalamin है, और साथ में neurologist को opinion भी ले लीजिए, who can do nerve conduction studies to really prove. But from the patient sake, we have to stop it. In your scenario जो बता रहे हैं, आप उसको जल्दी बंद करिए, नहीं तो वो irreversible हो जाएगा, फिर वो दिक्कत आएगा.
जी सर, thank you sir.
Yes, thank you.
Thank you. Then I close the clinic now. Thank you, Dr. Mehra sir, Dr. Bharadwaj sir, Dr. Diwan, and all the senior faculty who have joined us. Thank you. Thanks a lot. We close the clinic now.